I think it's time. Okay, so we are welcoming later our participant will coming into the webinar too. In the very beginning, I would like to introduce what is going on today for our webinar. So good morning and good evening. I'm P.Y. Cho and my colleague Jun An Yang and the junior too. We will moderate this webinar together. Welcome to ICC webinar today. We are so happy to have Professor Andrew Wexler with us. And Jinan will introduce Dr. Wexler. Jinan, please.
Okay. Thank you, Dr. Zhou. And hello, everyone, dear teachers and colleagues. I'm fifth-year resident Junan Yang. And please allow me to give a brief introduction about Professor Wexler. So Dr. Andrew Wexler is the Southern California Director of Craniofacial Service and Chief of Plastic Surgery at the Kaiser Permanente West Los Angeles Medical Center. And he's also a clinical professor of plastic surgery and University of Southern California. And Dr. Wexler was graduated from Boston University's medical school in 1980. Then he completed general surgery, surgical training at the University of Massachusetts and plastic surgical fellowship at UCLA. And Dr. Wexler served as the president of the American Society of Maxillofacial Surgeons. He's a senior board examiner for the American Board of Plastic Surgery. He has served as chairman of Surgical Advisory Board of Operation Smile. And since 1993, Dr. Wexler has led Operation Smile surgical missions to Kenya, the Philippines, Ecuador, Brazil, and Vietnam, and India, Cambodia, Morocco, many countries, and providing free medical care to hundreds of children with cleft lips and palates and other facial deformities. And his research interests are plastic and reconstructive surgery, craniofacial surgery, liposuction, neck lift, breast reduction, scar removal, and sclerotherapy. So today we're so honored to have Dr. Wexler with us to present the topic about global surgery and building craniofacial programs. And also today we have 4 important and experienced craniofacial surgeons who are invited to the panel. Professor Jung-Hoo Choi from Asan Medical Center, and Professor Hyun-Jun Seo from Busan Medical Center of South Korea, Professor Ghulam Ghadir Fayaz from Cleft Hospital Lahore of Pakistan, and Dr. Nisha Murali from Bhawan Mahavir Jam Hospital of India. And let's welcome Professor Wexler, please.
Thank you very much. My only corrections to you are that no, I don't do any of that aesthetic surgery or liposuction. Strictly reconstructive. This is what happens when we take a look at the internet for getting all of our information, unfortunately. And at this point, instead of being chief and regional director, I'm emeritus, as I retired from that practice a number of years ago just to concentrate on global health issues. But thank you for that kind introduction. And thanks to Dr. Pang-Yong Cho for inviting me to give this webinar today. I feel very fortunate in my life in that I have been able to do this work internationally. And oops, let's see, pardon me, there we go. And over the last really 30 years of my work internationally with not only Operation Smile, but several other organizations as well, I've worked in a number of countries throughout the world. This has, for me, I think, given me a sort of a global perspective on where surgery is today, and that has become a major interest for mine over these many years. And hopefully I can bring some of that to you here today. But before we get started on that, I think it's very important to take a look at the global situation as a whole. We cannot look at global health until we look at global economics and the current state of world development. We have approximately 7.8 billion people in the world today. And the interesting thing about that is when I was born, we only had 2.6 billion people. And in the course of my lifetime, going from 2.6 billion to 8.8 billion has created tremendous changes in not only environment, but opportunities for people in healthcare. And this global population surge is obviously putting strains upon our entire environment and globe as well as our economic situations. And that's just in the course of one lifetime. And we are expecting more as this logarithmically grows, of course. Over 3 billion of the people living in the world today live on less than $3.50 a day, and 80% of the world population lives on less than $20 a day, which is fairly staggering for a concept for people who live in Western countries who just do not see that part of the world through that lens. If we take a look at the distribution of population in poverty thresholds, and we take a look here at the very bottom, by the way, can you see my arrow on your screens, just out of curiosity? Yes. Good. We're seeing that actually the amount of people in severe poverty here is going down. Unfortunately, because of COVID and because of recent wars and so on and so forth, this is actually starting to bump up a little bit, and our progress in that direction has been slowed. Current estimates in the World Bank are that 8.5 to 9.3 of the world population is in extreme poverty. That means less than $2.25 a day, approximately 685 million people. The hope was by 2030 to be at 3%, but currently we're at 7%, and unfortunately that has been rising a little bit as opposed to getting smaller. And that's partially the result of the war in Ukraine, partly the result of COVID and economic slowdowns and inflations in various places. And so some of our progress has been lost recently, but the hope is that we should be back on track in the next few years and to get to a smaller and smaller percentage of the people who need help. Just an example, in Honduras, for example, village life, many of the girls there are married at age 16. Over half the population of Honduras cannot read or write, and horses are still used as a great deal of transportation. This is helps us understand in some ways, of course, why so many people are leaving these types of environments and traveling, and immigrants are trying to travel to countries that are better situated with better economic systems than they have in their own homes. About 780 million of the world's adult population is still not literate. 2/3 of them are women. The scale of illiteracy amongst youth is estimated 122 million youth globally are illiterate, of which young women represent 60% roughly of that population. And when I say illiterate, I mean illiterate to the point of not being able to write their own names. So it's not just not to read well. Okay. 1 billion people in the world have no electricity, which is about 13% of the world population. The pictures, by the way, the photographs are all mine through the various countries that I have taken over the years. There's about 660 million people without clean water, most of them in Africa, and that is going to be increasing, as we are seeing, particularly with our current climate change and increase in heat index. About 2.4 billion are without sanitation, and almost a billion people practice open defecation. This, of course, leads to greater amounts of disease throughout the world. By 2030, half the world's population will be water stressed to climate change. And that equals economically about 250 billion lost in GDP per year due to poor water and sanitation. And this is obviously getting worse and not getting better. So what are the health consequences of poor water and sanitation? Well, about 842,000 children under 5 die each year from diarrhea and dysentery. It's 11% of the world's population. Lack of water for agriculture leading to malnourishment. 155 million children under 5 have stunted growth, and 1 in 9 are malnourished. Once a child has stunted growth, and even if they get food later in their life, they never re-attain what they might have been had they had food early on. In terms of intellectual development, in terms of their abilities, have been stunted throughout their entire life because of lack of proper nutrients as children. About close to 500,000 people become blind due to vitamin A deficiency. Half of them will die. And the solution to that is simply a few drops of vitamin A in their water. And that could eliminate that whole problem. But the distribution and the money able to do that and the ability to educate people to do that, of course, is somewhat limited. And that's why we still have a number of these problems. About 13%, or about close to 800 million people in the world, do not have enough food to lead a healthy, active life. That's about 1 in 9 people on Earth. The vast majority of the world's hungry people live in developing countries, where about 13% of the population is undernourished. This little boy here has a big belly, not because he is full, but because he has marasmus and protein deficiency. But what we look at, when we take a look at diseases on Earth, most people concentrate on malaria, HIV and AIDS, tuberculosis, and parasites. And you see here the amount of deaths that each one of them, causes throughout the world. And again, this represents major amounts of morbidity and mortality throughout the world. And when we try to measure the effect of some of these diseases or the effect of any healthcare issues, we look at what's called a DALY, or a disability-adjusted life year. A disability-adjusted life year is defined sort of as the following. Let's say I have a hernia, and because of my hernia, I can't work that year that I have my hernia until it's fixed. Well, I have lost 1 year of it. That's one disability-adjusted life year. So for every person who cannot work or cannot contribute to their economy because of disease, that equals a disability-adjusted life year for that period of time. And the effect of all these diseases, major infectious diseases, ends up costing about 96 million disability-adjusted life years. So there's a huge impact upon human economy and the ability for many of these countries to develop because of the disease burden which they have. Maternal mortality in high-income countries, about 1 out of 3,300. In Africa, it's about 1 out of 41. And child mortality is 100 to 160 times greater risk of dying than, for example, in the United States. Malaria deaths by world region, however, are going down, which is terrific. We're making significant inroads in terms of the control of malaria, number one. Number two is that there's a vaccine that's going to be coming out shortly. It's starting to be used now for malaria. We have a brief uptick now because the mosquitoes that carry malaria are now able to go further north due to climate change and warming of the more northern zones within the world. So we'll have to see where that goes, because the uptick is now we're actually seeing a couple of cases of malaria in the southern United States, which we have not seen for many, many, many years. However, global number of AIDS deaths are going down. We've made tremendous progress with antiretrovirals with regard to the control of HIV. There are more people now living with HIV, but that means they're living despite the fact they have the disease. And the amount of new infections is going down as well, which means that our control and education with regard to the disease is certainly getting better. So these are all very promising in that area. If we take a look at annual per capita expenditures of GDP on some of the poorest countries on Earth, and we take a look at these countries and see how much they actually spend on per individual on healthcare and how much of their GDP that's equal to, you see that here. In the United States, we spend $8,500 a year per person, which is ridiculous, and 17% rapidly growing to probably 20% of our GDP, which is unsustainable. The next closest European country to us is the Netherlands with about a 12% GDP. We do not have a good system, and we do not get good healthcare results in the United States. In fact, the World Health Organization ranks us as number 37, below Costa Rica and just above Slovenia. So not terrific, despite the expense. So money alone does not make it. You have to have systems that work well as well to provide that kind of care, when our system, which is profit-based and not patient-based, has some severe deficiencies. In 2015, the UN got together in Doha and had a conference, UN Sustainable Development Goals. And they put together 17 goals that they wish to see by 2030 that the UN would work on with its affiliated agencies to try to improve what's going on in the world today, both economically and by health as well. And I want to zero in on goal number 3, which is the goal of good health and well-being. If we take a look at these sustainable development goals, these were to be achieved by 2030. We see in goals 3, and I highlight the red aspects because that indicates epidemics, HIV, tuberculosis, malaria, neglected tropical diseases, so on and so forth. We want to, improve newborns and children deaths. We want to improve, premature mortality from non-communicable diseases. And we want to do medicines and vaccines and development of vaccines and medicines and all this type of stuff, which is noticed in this throughout this development number 3. But the thing that is missing, that you do not see at all mentioned in this, is surgery. Nowhere in this development guide has anyone mentioned the amount of surgery necessary to keep people healthy. Okay, they have ignored the field tremendously. So in 2015, the Lancet Commission, which was a commission by Lancet magazine that had its origin really in Boston on Paul Farmer's group, and includes a couple of craniofacial surgeons, including John Mera here, who's in Boston, and Nivaldo Alonso, who's in Brazil, as well as Paul Farmer and Atul Gawande, who you may be familiar with as well from his writings. got together and put together a global surgery evidence and solutions for achieving health, welfare, and economic development. They're really the first people to really examine the effect of poor surgical systems or lack of surgery on healthcare as a whole throughout the world. And what they found was that 5 billion people lack access to surgical care, about 2/3 of the world population. Only 6% of populations in low and middle income countries have proper access. And that surgical rate calculation was you need about 5,000 operations per 100,000 people to keep people healthy. That surgical defect was 143 million cases a year needed to save lives and prevent disability. In the African surgical outcome study, the operative mortality, however, was 2 times that of that in high-income countries. The consequences of that surgical defect were that 16.9 million lives are lost, almost 33% of all worldwide deaths. That's more than tuberculosis, malaria, and HIV combined as the result of lack of good surgery. Yet the focus has always been by the UN and the World Health Organization on infectious diseases. Okay. The economic loss is 77 million dailies. Okay. And in terms of money, that's equal to about $12 trillion over the next 15 years. So there is a huge cost to not having adequate surgical care. And the estimation of cost to provide the needed surgery is about $350 billion over the next 15 years, or $23.3 billion a year. Now, you say, well, that seems like a lot of money. It's not within the global scheme of things, because if you take a look at the Pentagon budget in the US, it's $846 billion per year. Okay, so this is a drop in the bucket that could be expended to really have a huge effect upon global health. If we take a look at the global burden of operative deaths, it's suggested that 4.2 million people worldwide die within 30 days of surgery every year. Half of those deaths occur in low and middle income countries. It equals 7.7% of all deaths globally from everything. It's the 3rd greatest contributor to deaths after ischemic heart disease and stroke. More people die within 30 days of surgery annually than from all causes related to HIV, malaria, tuberculosis combined. It's a huge amount, and it's been basically ignored for years and years. The African outcome study found that despite being younger with lower surgical risk profiles undergoing less complex surgery, patients in Africa were twice as likely to die after surgery when compared to their outcomes with global level. So huge amounts of things have to be done in these countries to help improve the surgical healthcare. Now, the UN put together a list of common operations. They said, okay, if we're going to monitor this, we must identify basic operations that need to be done all over the world. And if we follow these, we know that any of the things that we are trying to institute are actually getting better. The UN is good at some things and not so good at other things. What they are really good at, though, is getting statistics together and examining systems and providing data along with the world through the World Health Organization. They found the most commonly treatable conditions were appendicitis, obstructed labor. About 15% of pregnancies require surgical care. And if they don't get it, often the mother and child dies. Hernia, fractures, congenital anomalies, breast and cervical cancer, trauma, and burns. And, we are particularly interested in dealing with congenital anomalies as craniofacial surgeons, and also with trauma and burns. So if you take a look at this herder in Ethiopia and you say, well, what kinds of obstructions are to him getting surgical care? Let's say he's got an acute abdomen. Let's say he falls and breaks his leg. Well, what does we have to do? Well, is surgical care accessible to him? And the cost of travel to him, can he actually travel to someplace that can get him that surgery? Because for some people, that cost of travel just to get to someplace that he can be treated is catastrophic with regard to their own economic condition. This man may not be able to leave his cows or leave his fields, particularly during harvest season, without his family starving to death later in the year. So accessibility, being close to having something that you can be someplace where you can be treated is very important. Ability, once he gets to the closest healthcare facility, do they actually have the ability to treat him? Do they have an OR that can treat him? Do they have surgeons who can treat him if he has a surgical problem? And of course, affordability. Can he pay for it? Most of low-income countries do not have systems of insurance, and it's a pay for for treatment, and often before you get the treatment. And if we take a look, here was a hospital charges, which they post in Lamu, Kenya a number of years ago. And $1 is 42K shillingis, which is what is listed here. If your average person in these countries is making, $3 a day, and which is equivalent to, let's say, 150K shillingis a day, and you take a look at this, can they actually afford to have any of this surgery done? Many times the surgeon will say to them, well, you have to go out and buy the sutures for me to be able to do the operation. So they have to go to the market, find someplace that sells sutures and get the sutures for the surgeon because they don't have supplies of them. And if that suture pack costs them $6 or $7, you know what? They're not going to get that operation because they just can't afford it. So many of them will turn to this fella here, like a medicine man, which you see in Tanzania. You see his various potions and lotions here that he would use on people. And the World Health Organization says, about 80% of the population in low-resource countries use traditional healers instead of finding a healthcare center that may be actually able to help them more. And of course, this delays good care. So now when a patient finally gets to the hospital, they're at a much more advanced state of disease than they would have had a hospital been available to them earlier on. Okay. We take a look at most healthcare systems. They usually start with a local clinic, then a district hospital, and then finally a tertiary referral center or a university hospital. Here's a rural clinic, for example, in Bagamoyo, Tanzania. And at this little clinic here, as you can see, this is the maternity bed. Most people give birth at home, but here would be the maternity bed for those patients who might have further problems. It's not very sophisticated. And in fact, the doctor comes here maybe once a month. And the nurses here were illiterate, even in their own languages, to the point that they could not write their own names. They knew how to give the injections. They knew how to give medications, how to weigh the babies, create, write down the numbers for data, but essentially they were functionally illiterate. So the next step up, this would be a local or regional hospital in Santo Domingo, Ecuador. Somewhat run down. It's a little more of a hospital-like thing that you're used to seeing, but aside from, these are all our actually supplies that are here, but aside from our supplies that are here, it's a rather bare type of operating room with limited amounts of supplies and availability and technology to provide for safe surgery. Now you take a look at, say, for example, the ward in the regional hospital in Mombasa, Kenya. Well, with a little help and, a good number of volunteers and a little money, you can make this into a more modern situation where people can get good care. Now, you can take a look at these university hospitals, because most of these countries now have university hospitals in their major cities. And these university hospitals are often built by, the Russians, the Chinese, and so on and so forth. And there's a ribbon cutting ceremony and everyone's happy. And, they say, oh, look at this wonderful thing that's been built and it looks great on photographs, and the political people come by and everyone congratulates each other. But a hospital is not a building. A hospital must be filled with, beds and IV poles and equipment and technology and sutures and, pharmacies and all those other types of things. So when you look at these lovely looking university hospitals and you go inside, this is what you might see, because none of the resources have been provided. I mean, these have been political statements rather than healthcare initiatives. And so you have this university hospital in Jimma, Ethiopia, and this is the level of care in their university hospital. Okay. Here's the university hospital, another, people sitting in the wards there. It's pretty basic. However, that doesn't mean that there aren't things that people who come to help can't do. For example, this was the night shift entertainment in Mekelle, Ethiopia, where they were killing cockroaches on the floor. The nurses would have a competition to see how many cockroaches they could kill during the course of the evening and compete with each other for various night shifts. So when you can't do much, there are some things you can at least do to keep yourself busy. I have my own development scale, which I have seen over the years, and I call it the clinic sink development scale. And my clinic sink development scale here's the university hospital in Antamarino, Madagascar, which is the capital. And here the input is very good in the sink, but the output isn't so good. And every 20 minutes or so, a guy would come by and empty the bucket. Okay, that's so good input, not so good output. Here is the one now in Kathmandu, Nepal, which has very good output, but no input. The guy would have to come by with a bucket to help you wash your hands. And then here we have in Puno, Peru, for example, where, oh, look, we have good input and output. But the problem is, if you stepped on the pedal, the water would spray all over the place. You would get soaked. It would soak the floor. And so nobody used it. So you still had to wash your hands in little buckets. So that's my clinic sink development scale. I have not published this yet, but I hope to be able to correlate this with outcomes. Here, for example, is the blood bank in Tegucigalpa, Honduras, okay, at a major hospital there in the capital city. Well, here's a centrifuge, here's a bottle of Pepsi, here's some nurses' lunches down here, and oh yeah, here's some packed red blood cells over here. So that's the extent of their blood bank. And this is obviously a very sophisticated donation here, probably from the Pepsi company that they can use for their blood bank. So when we take a look at some of these problems, we have to say, well, what do we need to know? How do we examine these types of things? How do we know it? We have to get data, and we have to be able to get through the obstructions of getting it, because data is neither good nor bad. It's just numbers. It's just data. It tells us what's existent. The problem is in many of these countries that governments and political organizations don't want to hear the data because it makes them look bad. So, for example, when I was in Kenya in '93, when we tested children for HIV, we had 14% of the kids were HIV positive. And at that time, they were all going to die because we had no treatment for them whatsoever. But the next year we came back, the government would not allow us to test the children, would not allow us to gain that data because it made them look bad. So we have to get past that concept of judging the data and just looking at it as being data that we can do something with, that helps us to improve things. And then we have to say, well, how do we fix it? And then we have to say, are we successful? So after we institute something, we have to go back and say, what are our long-term results? Have we actually decreased those, for example, when those 5 operations that I talked about earlier that the World Health Organization identified, are we making progress in terms of the number of people who are able to get those operations successfully? So again, the World Health Organization took to look at some bellwether procedures, C-section, laparotomy, open fracture repair. And these are the types of things that they are following currently to seeing if the various types of interventions that are being used are actually making a difference. And they are. We're making progress in all of these areas. So the World Health Organization surveyed 800 facilities in low-income countries. 31% of them had electricity. 2% had adequate water. O2 was only 24%. ERs, maybe 31% of the hospitals had ERs. 55% of district hospitals in 8 African countries had no anesthesia in the machine and no pulse oximetry, 70% no pulse oximetry. In Zambia, 28 district hospitals, 35% had no laryngoscopes. So they're not doing much surgery there. They're not doing much safe surgery there, that's for sure, okay? And when they viewed things, 40% of donated items are out of service. So you think, well, oh, we donate items, things are going to get better. No, you can't just donate an item. So the World Health Organization's guidelines for donations are that it has to be driven by sight. Don't go and give some sophisticated piece of electric machinery if they don't have good electricity. Don't give them lab products if they don't have a lab. So you have to know what they actually need, and you have to ask them what they need. And they must include long-term maintenance. I can tell you I was working in one hospital in Africa, and we were soaking our instruments to sterilize them. And I walked into the next room, and there was this huge state-of-the-art German sterilizer. And I turned to one of the local surgeons. I say, why aren't we using this? Why are we soaking our instruments? He says, well, it was given to us by the Germans, but nobody knows how to connect it. And there was no service for it, and we have no parts for it. So it's just been sitting here for the last 7 years unused. And this is the kind of problem you see continuously all over the world. So you have to discard, you have to understand that anything that's donated must come with maintenance, must come with the ability to get spare parts for these things as well. And to discourage the donation of consumables, because they don't last and they disrupt the supply chain. What do I mean by that? If you come in and give a hospital 3 months supply of surgical sponges, well, you know what? The, Omar on the coast, who used to sell them the surgical sponges and was making his business doing that, goes out of business because he's no longer selling surgical sponges to them because they're using all the sponges you gave them. Now, when their sponges run out, Omar, who used to supply the sponges, is no longer there to supply the sponges. And now they have a bigger problem. So consumables disrupt the supply chain of these countries and should not be given as a donation. The other problem is in low middle income countries, managerial tasks are left to clinicians. There's no professional management. So let's say the chief of surgery is asked by the Minister of Health, I want you to run the hospital. Well, the chief of surgery may be a great surgeon, but he has no knowledge whatsoever how to do all of the tasks that it takes to monitor a hospital and to make a hospital run efficiently. And he's got his own practice to try to run and make his own living, and he can't do this type of stuff. If anyone wants to know about how to do that better, this is a very good book that I ran across and read about, how do you manage these systems? How do these systems work? It's a very good basic book on how to make, these systems in low-income countries available and functionable and all this sort of stuff. Okay. So what's the single most detrimental factor providing healthcare in low-resource countries? As far as I'm concerned, it's governance. You bring money into countries. If you run it through the government, half of it, goes into other people's pockets and not into the healthcare system from corruption. Government policies, political policies get in the way between a doctor and their patients. These decisions for healthcare are being made by politicians who know nothing about healthcare in many cases, and this is a real problem. 93% of sub-Saharan African peoples live under non-free or partially free regimes, and as a result of that, their lives are completely controlled, and they don't have the ability to really change any of that for themselves. Okay? So let's take a look at my experience in terms of doing the work. So you have to first identify where the need is. Okay, in the United States, virtually every child with a cleft gets care in infancy. This is not the case throughout the developing world. Our appearance and how we communicate with each other is essential to successful social interactions, no matter what our culture is. And for example, a smile cross-culturally is the way that people meet one another. It is our expression of emotion. It is a greeting. It is essential for interacting emotionally with other people. And our facial appearance is critical to that. It allows us to be parts of society. It is our facial organ, essentially. And so let's say you want to run a mission, as help piece. Now what? Planning and safety. Well, as my daughter, the gymnast, might say, don't attempt this without planning, training, and forethought, because you will crash and burn. So don't try to do that. So I ran a international symposium a number of years back in around 2007 or 8. And after the symposium on clefts, a number of surgeons from low-income countries came to me and says, you've got to stop your surgeons from coming to our country and creating a mess. They're leaving behind complications. They don't know what they're doing, many of them. And I said, listen, I've got nothing to do with that. You're letting them into the country. You're putting them up in your hospitals. I have no control of that whatsoever. But I understood that there was a real problem because they were being left with complications by surgeons who didn't know what they were doing, were not performing safe surgery. There were increased numbers of deaths and so on and so forth. I wasn't the only one to recognize this from their complaints. The World Health Organization understood this as well and came out with guidelines for safe surgery in 2009. Around that same time, global standards for Operation Smile, we brought together 60 people from all over our countries that we serve in Norfolk, Virginia, and we had a conference that lasted a week. And we said, what are the standards that we can apply to these countries that make sense for these countries that we can provide safe surgery? And in 2010, we published that, and all of the teams had to follow these standards. Additionally, in the Plastic Surgery Society, we created a committee called VIPS, the Volunteers in Plastic Surgery, and we published at that time guidelines for providing surgical care for children in a less developed world. And we published that in PRS in 2011, and that was adopted by many of the teams going in to doing this kind of work. Additionally, I was asked to chair a team of pediatric anesthesiologists and myself with regard to updating all of these guidelines. And these guidelines that we just published in pediatric anesthesia in 2020 have now been accepted by multiple major organizations throughout the world, including the European Society of Maxillofacial Surgeons, Pediatric Anesthesia, the South African community of pediatric anesthesiologists, and many of the other organizations who do this work throughout the world. And we take a look at what's in this. Well, there's site visits, initial groundwork, equipment, patient selection, procedure selection, sterilization, all the types of things, step-by-step checklists that make a difference to providing safe surgery in these countries. So, for example, selecting a location. Is there a need? Do they want you there? Is there coordination? Are there other organizations providing the same service at the same time? You don't want to come into a place where another team has just been there and there's nothing for you to do because they've done it all. You have to have that coordination. Logistics support, housing, transportation, professional support. Is the local community of surgeons there going to help you, going to be supportive of what you're doing? Political support. Is the Minister of Health on board with what you're doing? Team safety. Is it a safe place to visit? Hospital selection. Does it have electric? You must do a site visit. You have to see, does it have electrical power? Does it have good anesthesia machines, oxygen, monitoring, suction, laboratory, all the things that can provide that? If they don't have it, you have to think, if I'm going here, I'm going to have to provide it. So how am I going to do that? And Operation Smile's global standards gets very, very granular, as does ours. And they're looking at, what size even pediatric anesthesia tubes you're going to need. You know, what is the concentration monitors? What monitors do you need? And it goes on in terms of step by step by step in meticulous detail, which is what you need to provide safe surgery in these places. Okay. In developing countries, your efforts don't always have predictable consequences. You have to deal with that, and you have to be very flexible. If you can't count on the systems and structures to work for you, what you expect in your country is not going to happen in these countries. And you always have to consider what if and backup, and not only backup, but secondary backup. So if this is my waiting room, when I come in my first day of doing a mission, and I've got several hundred people there, how am I going to provide safe surgery for these people every step of the way? And what I do is I follow the patient in terms of from the time they check in, getting the right medical record number, the photography, so on and so forth, right through to pre-anesthesia and pre-op and so on and so forth. And every step of the way, when I lead a team, I say, what can go wrong here and what's our backup? And I can tell you that if you don't have those backups, you've got a big problem, because I can tell you in one case, we were operating first cases in the morning, 2 infants on 2 separate tables. They both coded simultaneously during induction. And why? Because the man who supplied the oxygen to the hospital at that moment decided to change out the oxygen system without telling anybody. Fortunately, because we are prepared, we had H tanks available there, switch over immediately. We're able to resuscitate both children successfully, but only because we had backups and we had a very highly trained team who knew how to immediately switch to that and be able to do this in a smooth, trained fashion. We have triage. You cannot do patients, certain patients, even though you'd like to be able to do them in your own country, perhaps, but in these countries, it's just too dangerous to do them. This is neurofibroma. And you notice that this woman is wearing, you know, pearls around her neck and is well-dressed because she works at the bank every day, because she must work in order to live. There's no ability for her not to be working, otherwise she would starve to death. This child with a very unusual, rare mandibular cleft, or this child with arrhynia, these are cases that you see, but unfortunately, you can't treat in these areas because you just don't have the capability to operate in these kids successfully, or with frontal encephalocele and things like that. These are what the wards may look like, you know, preoperatively. Patients come with their own families, and they come from hundreds of miles away, and they may take them a week to get to your site. And so you've got to prepare for them and their families, and what are they going to have for food and water, because the hospitals don't provide that. I'm going to use Operation Smile for some of the references I show here in terms of what team makeups and what a team is like, and mission type surgery. And these are the types of people you need. And I tell you, the most important people you have here are translators and biomed. Incredibly important with regard to being able to provide safe surgery in these places. And safety, safety, safety. This is the most important thing. It's not only patient safety, it's also your team safety. In terms of patient safety, you know, age less than 1 year have, for anesthesia consequences and mortality, 1-year-old children have hugely increased amount of operative death. They have to be ASPS3 greater. Poor nutrition, children that are obviously malnourished, and height, weight, or head circumference don't do well. Hemoglobin's less than 10 don't do well. Significant airway anomalies, intercurrent illnesses, you know, respiratory illness in these countries. You hydrate up a kid, he's got, you know, a past history of respiratory, he can cough up a mucus plug and die. And I've seen that happen. Syndromic children, you don't want to have that. And you cannot push the margin of safety. What you can get away with in your country, you cannot get away with in these countries. You have to have written protocols and procedures, and you have to follow them. You need team communication. And that means language and empowerment. Everyone must be speaking the same language so that they understand each other. And you have to empower everybody in that team to speak up if they see something that's unsafe. In many countries where, for example, women do not have the social status of men, or nurses do not have the social status of doctors, they are afraid to speak up and tell the doctor, you know, I see something here that's wrong. And as a result of that, deaths can occur and safety issues. So you must break down, you must level that playing field with regard to your team, with regard for the ability to speak up with regard to safety situations. People must be empowered to speak up. You must have proper monitoring, and the guidelines all cover that kind of thing. For your team, you've got to have secure lodgings, adequate water, particularly in hot environments, food safety, hand washing, environmental safety. You can't help others if you can't help yourself. I have been incontinent in every continent, and I've had IVs all over the world because I've gotten sick. And when I'm sick, you know, it's tough for me to deliver the type of care that I wish to do. Okay. You have to be organized. You have to be creative. You have to be flexible. These are just the boxes that our supplies came in, and immediately our nurses were able to set up an entire storeroom completely organized and ready to go, so everyone knew where everything was. Okay. Many times you'll be coming to little airports in the middle of nowhere. You may be staying in hotels that are somewhat less than what you're used to. In this hotel, for example, I had hyenas scratching at my door at night because they were hungry. Room accommodation, sometimes you get nice places and sometimes not so much. It really depends where you are in the world. This is the recovery room in Phnom Penh, but I can tell you here that every one of these beds had proper monitoring, had oxygen, and had suction, so we could provide safe care. The wards themselves can be unair conditioned, they can be full of people, and I really admire the post-op nurses who take care in here because it is a long, hot, and very difficult day taking care of the kids in these types of situations. These are where many of the patients come from, these little villages. They don't have electricity. So you think post-op care, what's your infection rate going to be? Are they going to get the proper type of care in these places? And many times that's very difficult. If you take a look at the structure of a team, various things that if you look who you need preoperatively, operating room, recovery room, post-op, what kinds of people do you need in these situations? These are the types of teams that you need to have. This is a setup for an Operation Smile type of team. But you're working with some of the absolute best people who you've ever worked with in the world, from all over the world. These are ultimate professionals, whatever anesthesia or nursing. The people I have worked with over the last 30 years have been some of the finest people in medicine that I've had the opportunity to work with. They are of one heart, they are good giving people, and they really know what they're doing. We also bring along, in Operation Smile, we've also brought along teenagers to teach them the value of giving, to teach them the value on a mission. We were in Brazil, and she said, you know, Dad, this is the first time that I've been able to help other people where everyone else has always given to me in the past. And she went on to become a craniofacial. She worked for Operation Smile for 3 years as a commission coordinator, then went to become a craniofacial PA, which is what she does now in Seattle at Children's Hospital. You take an empty OR, you fill it full of great people, and you can actually get work done. These are just the daily schedules in one of our missions. Each one of those little boxes is a case done for that day. And you can really, if you're efficient, do a tremendous amount of good for a tremendous amount of people. But now we're switching. We're going away from the mission because the concept with the mission was we had nobody there to train. Currently now, with increasing residency programs in these countries, with increasing young surgeons, we are now doing more mentoring. We are now sending in just individuals to train people, more education than just service missions. And this is where the real sustainability comes with regard to health. Mentoring is incredibly important now. Here's in Bangladesh, the young surgeons, the young interns that we were working with there. And in fact, we get to have a lot of fun as well, dealing with these kids. And the kids, I say, but they're young doctors, kids to me. Additionally, we have bidirectional education. We run conferences in these places. And you can learn, I mean, many of these surgeons know a great deal. They just don't have the resource to provide them. And we learn from their experiences. And I've learned all kinds of interesting technical abilities from people who don't have the resources that I have. And so it's bidirectional with regard to the education. Because there's a lot to learn from both ends of that spectrum. But the important thing is that, these mothers and their children come from, great distances, hoping to have their children repaired. You remember these kids. You remember Chastity, is this child in Kenya who was burned terribly, but missed the mission before, waited 3 months in the hospital corridors, begging for food by herself at 12 years old, waiting for another team to show up to free her from the prison of her own flesh and burns, which we were able to operate on. This little boy, Charles, bitten by a cobra and had total necrosis. We could not obviously provide him with great function, but we could provide him with release of contractures and better ability to use that arm to aid him. Or this girl from Cambodia with Noma, who they called me a week before and they said, can you fix this? Can you make this better? Before I even got there, because it's going to take us a week to get there from where we are. An aid worker called me and I said, yeah, bring her down. Let's see what we can do. This is all terrible tissue here. And I said, listen, I can't make this pretty, but I can make this functional. So with just local flaps, because you have no ability to do anything too fancy, at least I could provide a competent mouth for her to continue to eat and to be more normal within her society. Or this little girl who was 12 years old, who was a servant to a more wealthy woman in Kenya, who would not allow her to see anybody she had to stay in the back rooms all the time because she was not allowed to be seen by anybody. And her isolation, be able to fix that little girl. Or this little girl who just wanted to be fixed to go to school, which she couldn't before. Or Daniello here in Fortaleza, Brazil. He's 17 years old. What do you want from this operation? He says, someday I just want to be able to kiss a girl. And just something as simple as that. Or I also just want my father to hug me. He has never hugged me. So you can do a tremendous amount with what you've got. This gentleman, 70-something years old in Ethiopia, fixed for the first time. Or this child, what you really are looking for is here's a big bilateral cleft lip and palate. And the next day, he gets to look at himself in the mirror and see an image that he has never seen before that changes his life totally. And this is the excitement you get from this sort of thing. And you take these kids and their mothers, expectant mothers, and return them to their families. And you can actually feel the love that these parents have for their children and know that at this point, what you have done has changed the lives of these children wherever you're working. And what I have found, no matter where I have been throughout the world, is that one thing that is universal, one thing that drives us all as human beings is love of parents for their children. And that is a palpable energy. And when you fix a child, some of that energy comes back to you and you feel that love from that family. And it makes, it's as addicting as a drug, and it makes you want to continue to do this work time and time again. So we're a world community. And I have to tell you that there's a word in Swahili, which I know, called Ubuntu. And what that means is a feeling of being one with all the people on earth, a feeling of community throughout. And that is what we really try to achieve in the work that we're doing. So Ralph Waldo Emerson in the United States in the 1800s said, to give of oneself, to leave the world a bit better than when, to leave the world a bit better by a healthy child, a garden patch, or a redeemed social condition. This is what makes our own lives worth living. So, so I would say to you the following: consider your opportunities. You'll never find a more rewarding experience, and I would recommend to you to be doing this work and to be involved in this work, because you will absolutely, it will change your life as well as the lives that you change. Thank you.
Thank you so much, Professor Wexler, for this amazing talk. I think I speak for everyone when I say that this talk was really touching and also gave us a lot to reflect on and to think about. And at this time, I'd like to invite our panelists for some discussion. So first of all, I'd like to invite Dr. Nisha Murali. Dr. Murali, would you like to say a few words?
Yeah, thank you. Dr. Wexler, I think that was a fantastic talk. Honestly, I am so inspired by the places that you've visited and the challenges that you've faced, and the kind of care that you are committed to delivering. I think it's definitely something that as young surgeons, we can actually reflect on how these kind of global challenges can be dealt with. For example, I think now we're all on the path to becoming global citizens, where we are transcending boundaries of language and culture and politics and mundane barriers like that. And I think this is an excellent step forward, where you've highlighted to us what are the important challenges. It's not just about coming and doing a surgery and leaving, but there's so much of planning involved, and especially with the pre-op care and the post-op care. I think that is what really makes the difference. And I think I really have to, I think it's very inspirational to listen to what you've told us. So I also have a couple of questions regarding when you travel for all these surgeries overseas. Do you typically like to take your team of anesthetists and nurses along with you, or do you rely on coordinating with the local healthcare professionals to help you during this?
So obviously, as we all surgeons know, some of the greatest risks we face is from anesthesia. So wherever I travel, either with a team, a whole team, where we bring not only anesthesia, but our own anesthesia machines, for example, with Operation Smile missions, and we coordinate them with the local anesthesiologists. And what we try to do is be able to evaluate local anesthesiologists and to certify them according to the safety standards that we have, that indicates that this is a certified person that we feel perfectly comfortable with, running a table and so on and so forth like that. But first, they have to be sort of certified by us to make sure that they're following the safety recommendations. I always travel with, even on smaller mentoring missions, we generally bring anesthesia. So it's myself and anesthesia and maybe a single nurse to work mentoring both operating room teams and anesthesia and surgeons, so that we're imparting information and imparting teaching to those people who are there, learning from them as well, of course, what their situations are, how we can be helpful to them, how we can work together to achieve better results. So yes, the answer to that question is anesthesia is, I consider, critical to be there with me. Yeah.
Right. And what about your post-op? How long do you typically stay after all these, after your mission surgeries are completed?
So it's a little dependent upon the place where we're at, but generally speaking, we want to coordinate with local surgeons who we're working with during that period of time to continue the follow-up on those patients. And in fact, we will generally, from the team standpoint, the international team will generally check up on them 6 months later. But the immediate post-op care is, we usually leave a couple of people behind for 2 or 3 extra days, just to make sure there's nothing acutely that we have to deal with. But after that, and the kids are usually discharged within 3 days after the surgery for the most part. And we only do the clefts at the beginning of the mission because they take a little longer to heal. And then the local surgeons who we've been working with during that period of time will provide follow-up.
Right. Thank you so much, Dr. Wexler.
Pleasure.
Thank you, Nisha. And next, I'd like to invite Dr. Sol.
Hello, can you hear?
Yes.
Yes, it was so a great presentation. It was so impressed me. And I think it is not easy to follow your way because many people think like you, but it is not easy to do some really things to help them. I have to ask some kind of personal question to you, Professor Andrew Wexler. So, do you have some kind of the particular event for you to interest in this kind of global healthcare problem?
Was there something that initially got me interested in that?
Yeah, something kind of particular
yeah.
event or. Yeah.
Well, when I was growing up, I knew a very good infectious disease doctor at Yale. And he was a friend of our family, and he would go every year. He would go and work in some exciting places around the world. To me, exciting places around the world. And I loved travel. I loved seeing other people. I loved other cultures. And I said, when I get to be a doctor someday, I want to do what he's been doing, to work in other places, to experience those cultures, to be helpful to other people who are really in need. Because to me, that was medicine in its purest form. When we're working in developed countries, medicine is a big structure and a huge. It's complicated by everything that makes it an industry, essentially. When you go to these places, it's what you wanted to become a doctor for. You wanted to become a doctor to help people, direct care. You wanted to say, I have a skill, you have a problem, and all I need from you is your thanks that I have helped you. And that's the purest form of medicine that we have. And I think that drove us all to become physicians and then surgeons. And so for me, every year that I would do this, I would step away from my own healthcare system. It would revive my soul and remind me why it was I went into medicine. And it would make the rest of my years so much better.
Thank you. Let me ask one more question, Professor Andrew. So I think always the problem is the money, I think. So how could you recruit or get some money from your mission trips or this kind of global health care?
Yeah, so many organizations, Operation Smile, Interplast, or what's now called Resurge, Rotoplast, there are a number of organizations, and of course they do fundraising, and it's part of the deal. You have to get that. Now you can get grants, and the other thing is that it's not just cash money that's important for being able to send people and so on and so forth, but it's also supplies. And a lot of main multinational corporations will donate to you, sutures will donate to you, and you just have to ask. You have to make the right pitch, and you have to have the right people to make that argument to them, that they'll say, yeah, this is good for us. It looks good for us politically. It looks good for us in the country where we're providing these services. It's a good photo op. you make it a win-win situation for them. But you have to be asking, you have to continue to do that kind of stuff. There are not a lot of grants available to do that. It's really, you have to do it from making, doing a talk like this to an audience that's non-medical. And at the end of the talk, you say, you can help support this kind of work by doing X, Y, and Z. And they can be moved by what they see, and they'll want to donate. So that's where the money comes from.
Thank you.
Thank you. So next, I'd like to invite Professor Fayyad. Professor Fayyad.
Hello. Hi, Andy.
Hi.
Very inspirational talk. And you have shown us, you have taken us around the globe in many different countries. I have been working with the Operation Smile, a number of missions. And at home, we have a foundation in Pakistan. And we also do missions in Pakistan. And my team have done 199 missions in the last 19 years.
Wow.
But I see the difference in Operation Smile mission and our mission is that we do not have any language barrier. We know each other for many, many years. We know each other capabilities. We know each other weak points. We respect the positive points in our team members. But when we go outside, a lot of time is used for interpretation. There are mock exercise which take time, and sometimes there's a lot of delay because the anesthesiologist will go and bring the patient to the OR. Sometimes I have to sit maybe 70 minutes or 80 minutes to wait for my next patient. Professor Lowe, Professor Philip Chen, and I wrote a paper in PRS Global Open in 2015, Model Humanitarian Cleft Mission, where we recommended that although it is not possible that the low middle income countries can develop their national team in a period of 1 to 2 or 3 years, but what we can do, that we should send a regular team to Fortaleza, Brazil, because the members know each other. They have a good rapport, they have a good liaison, they know each other, and they can support each other comfortably. And within a period of 5 years or so, the local team will come up. So I want you to share your thoughts on this very important issue.
Yeah, so obviously what we're all aiming for now is sustainability. It used to be when we went to places, there were no doctors even to train. And of course, as I spoke before, language as empowerment with regard to safety is very, very important. If you have a full team speaking one language, that's terrific, but they still must obviously communicate effectively with the locals there, whatever their particular language is. And that means you need translations and so on and so forth. But this concept of bringing teams in to create sustainability, to develop that, is obviously the goal of all these missions. And we have now seen in many countries where the international organization can step away and the local organization continues on, like you have a local organization in your country that is doing very good work. And all at that point you need is to send in educators, 1 or 2 people at a time to say, hey, here's some new concepts. Let me look and see what you're doing. Maybe I can be of help. Let me learn from you. You can learn from me. And that's the next step up as we progress. In one organization that I work with, not Operation Smile, but research, I was in Nepal 5 years ago. I trained their maxillofacial surgeons there to be doing better clefts and so on and so forth. This time I came back after COVID 5 years later. Now they have difficult cases and fistulas and tough noses, and they say, now let's work the next step up. And they're very good surgeons. And you make it each step, but you make progress. And I've wonderful to see in the countries that I've gone back to the development with time of the skill sets. And this is, of course, what we're aiming for, because at that point you can step back and go, you know what, you guys are on your own. You're doing a great job.
Thank you very much.
Thank you, Professor Fayyad. Next, I'd like to invite a good friend of Professor Wexler's, Professor J.W. Choi. Professor Choi.
Hi, Andrew. It's
Hello.
been a while. Yeah, so I'm really impressed about your 30 years the journey for the voluntary mission. Yeah, that is a really amazing job for 30 years. So actually one question, actually there, as you mentioned, there are so many voluntary mission groups. So do you think we need another or additional mission aid group in addition to the Operation Smile or other things. So, or we need to make the previous Operation Smile things, the groups bigger. Actually, which would be the more ideal, I think.
Yeah. So I don't know that there's an ideal solution. Let me put it to start with. There's plenty of work for everybody.
Yeah.
We're not going to run out of surgical operations to do. And of course, the more people involved in it, the better we're going to get at it. I think the key here is not whether it's one group or multiple groups doing it. The key here is that each of the groups that is doing it maintains the same safety standards. Because what was happening in the past is you would have these groups going in. There may be, 3 cosmetic surgeons who haven't done a cleft in 20 years, and I want to give back, is what they say. But they're not giving back. All they're doing is trading one deformity for another because they're not doing a good job. So I think the important thing is not how many teams are doing it, but the quality of the teams that are doing it and the understanding of cultural awareness of where they're going, and to be able to deal with those people on their site, in their cultural norms, and be able to provide safe surgery. That's the bottom line. Obviously Operation Smile tries to grow itself. These organizations try to grow themselves, but you get to a certain point where that may be difficult because it becomes too complex a situation when you get too big. You can outstrip your ability to provide good care. So obviously smaller organizations and other organizations, as long as they're following those same safety standards, are very important. I've always looked at my job is, throwing a stone in the water. Because when you help that kid, you help a family, and then you help that family, you help that community, and the ripples go out like that.
Yeah.
And it's like throwing a stone in the water. And I've always looked at my job as standing on the bank and throwing as many stones in the water as I possibly can, and getting as many other people to do that. Because when you do that, you can create a wave, and that can actually make a difference.
Yeah. Thank you.
Okay, thank you, Professor Choi. Next, I'd like to invite Dr. Bernard Tensipak.
Hi, I'm Dr. Bernie Tensipak from the Philippines. Can everybody hear me?
Yes.
It's quite sad that I saw 2 places from my country in your pictures because those 2 places were quite near our craniofacial center. And one of the case was a nasoethmoidal meningoceles, and we do about 120 of that every year. So anyway, let's just say my beef in this issue is, you say the coordination. Who does this? Actually, that's the main problem that I see, because in the last plastic surgery conference that we had, there was a confrontation between Smile Train and Operation Smile, and they were pressuring the Plastic Surgery Society of the Philippines to control basically control who does what surgeries in which site. So I think, pressuring the local society and making it a political affair is not a good start point when it comes to these missions.
This has been chronic problems throughout many organizations. They have to understand this is not competition. There's plenty of work for everyone to do. Certain organizations have felt that I want to create my market share, like a corporation does, or and this is not the way we should be practicing medicine. And these types of political issues only get in the way of providing good care. But this has been a chronic problem that has gone on for years and years and years. I don't see it going away except by, explaining to people and continuing to explain to people, hey, we're all on the same page here. We're all on the same team. We all want the same result. It's not about market share. There's plenty of work for everybody. It's not about other people's egos or your own egos. It's about getting rid of ego and just doing the work and getting rid of this political kind of.
I think it's more of the issue with the way the management of Operation Smile and Smile Train does their thing. But my number 2 point is, what's the end point of all these surgical missions? You say you are mentoring, when you go to places, you are mentoring them in the way you do your surgeries. In the same light, you are mentoring them in the way you set up your surgical mission. So the local surgeons end up doing missions of their own, and setting up the craniofacial center or a sustainable center is quite far off from what they learn. So I think this is what is lacking in the mentoring systems that I've seen. You mentor them in the way to do missions. So they end up doing their own mission. So it's going to be an endless cycle of let's just do missions because we were taught to do these missions. Instead of just saying, oh, we did missions before, now it's time to move forward and set up a standard that's sustainable, that's there throughout the year, et cetera, et cetera. So,
and this is exactly what Operation Smile is currently doing in some other organizations. We're actually building cleft centers that are sustainable centers manned by local surgeons and anesthesia and so on and so forth. We have an independent site in Honduras. We have an independent site in several other countries right now, and others more in the planning stages to create exactly what it is that you're talking about, to allow for that amount of sustainability. And when that's done, international organizations can say, you're on your own, you're doing a great job, see you later. But you're right, correct. Yeah.
Okay, thank you, Dr. Bernard. And last but not least, I'd like to invite Professor Low.
Hi, Dr. Wexler. Very nice to hear your talk and really appreciate your dedication of the crab care in this country. I can tell you my experience. We also do do mission and Chang team. We cooperate with Nordic Craniofacial Foundation. We also go to some Asian country, and we mainly go to so-called a big city. For example, in Cambodia, we go to the capital Phnom Penh. Vietnam, we go to Ho Chi Minh City. So we have a place that relatively have good facility. Well, listening to your talk in some African countries, the facility really is very poor. That you feel awkward to do this crab surgery. So in that sense, we are lucky. But we also focus on education to collaborate with the local surgeon, and hopefully they can be independent. We continue every year since 1998. We hope to go back to every year to the same center, same hospital, and to meet the local surgeon so that they can do a good care. And in terms of the surgical techniques, surgical facility, I do observe that in this country, Myanmar, Cambodia, Vietnam, they gradually improve. So this is the way that we're doing. I wonder if you go back to the same place, do you observe the same thing, that everything is improving?
Yes, absolutely. I'll tell you, interesting. So I was in Hanoi early on in the mid-90s, and I went back about 10 years later to lecture. And so I was explaining something, how I do clefts, and a guy in the back raised his hand. He says, you taught me that 10 years ago. I've been using that ever since, and it's really great. And I've been teaching all my friends. So yes, you absolutely do see changes when you go back to these areas. You see improvement. As I mentioned, when I was in Nepal, these young women surgeons who were there that I trained initially with helping them with the initial clefts and primary care, now they're looking for the more complex stuff. So you're seeing that improvement as time goes on. The skill sets are improving, the ability to provide good care. So yes, the answer to your question is absolutely, we are making progress, and I've seen that progress through my entire career.
Yeah, thank you, Dr. Wexler. I really appreciate your work. So it seems that we are in the same same idea, that in terms of the global crab care, really nice. Thank you very much.
Thank you.
Yeah, thank you, Professor Andrew, and thank you for your very experience to talk in the past 30 years to teach all, not only the experienced surgeon as well as the young generations, about what you have done, and to devote yourself in all kind of different kind of maybe the mission, charity, or to help the others who in need. At the time, I would like to invite all the participants in this webinar, and welcome to show your face, and we can have very lovely group photo. and especially to thank all of our panelists, even Professor Jungwoo Choi. You are so busy, I know, and Seoul, and thank you for you from the Busan and your kind word, and Professor Fayaz from Pakistan, Nisha from India, and the Berna is always our good friend from NCF Philippines. Yeah, thank you for your contribution. EK, Professor Handa, and yeah, our Linus Lee. Hello, Sang Ling. Thank you for your coming. Dr. Lee is our representative of NCF, the local team, our chief NCF in Taiwan. And I will count to 3, and please give me a lovely smile, and then we can together have a photo with Professor Andrew together. Okay, 1, 2, cheese. Yes. Thank you very much for your warmly to this, no matter you are in the daytime or evening time. And hopefully to see you coming to join the webinar in ICC next time. So see you. Thank you, Professor Andrew Wexler. And see all my friends.
See you.
Thank you, Professor Choi.
Soon.
Yeah, thank
Take
you.
care.
Thank you, Professor Fayaz.
Thank you.
Bye-bye.
Thank
Bye
Have a
bye.
good night. Have a
Good
good
you.
night.
Good
one.
night, everyone.
Thank you so much. Thank you, Berna. Thank you, Junan. Yeah. Thank you, Junior. Thank you, Sangling. Thank you, EK. Thank you, Nisha. OK，好
OK，
，Junior 晚
see
安
you.
喽，Junan 晚安喽，谢谢，拜拜。Thank you,
谢谢啊
home.
谢谢，拜拜。
拜。